Call the meeting to order. We have a quorum, and we welcome our guests. And this morning we have, as our ongoing study on the opioid crisis, we have from British Columbia, Dr. Evan Wood. I understand it's 5:45 there approximately, so thank you for being with us. And from Metadam, we have Guy-Pierre Lévesque, the director and founder of the Community Center. And we have Recovery Ottawa, Dr. Ujim Walla. Thank you very much for coming and making a presentation. And I understand that, Mr. Lévesque, you have to leave a little early, so we're going to ask you to start off with your presentation. So if you would start off with your 10-minute presentation, then we'll move on.
Should I put this on? Oh, it's... Sorry. Okay, so as I was presented, my name is Guy-Pierre Lévesque. I'm the founder of the organization Metadam, which is a peer-led organization. So everybody at our facility are peers, people that did or are still using opioid. We initiated the program, actually we started in 2013. Our program is called ProFan. We call it Aller plus loin, and it's prevention, réduction des overdoses, formation par les pairs et accès à la naloxone.
Training by your peers and access to naloxone. So, as I said, Metadon is based on empowerment. We work on improving the quality of life of those persons who take opioids, morphine, and others. We have community support. We also have, it's provided by the peer groups, of course, and we have some 20 housing units. Profan is in response to a statement by the United Nations in 2011 that said that it is imperative to include in the continuum of services offered to persons who are using opioids. So the word profan means prevention, reduction, overdose, training, access, and naloxone. It's really a prevention program. Our goal in this is to empower users to recognize the signs and the symptoms of an overdose and different drugs. Here, unfortunately, we are speaking about the opioid epidemic, but there are also overdoses from stimulants, and we have to be able to recognize the difference. And we train users in terms of RCR, breathing, and what to do if there is an overdose, because if there are too many constraints on the user to react in a certain way, we train others around them to do so. The goal, of course, is to reduce, and that is the ultimate goal, is to reduce the number of deaths by overdose. We have set out a strategy that involves quite a number of partnerships with doctors and to ensure training with naloxone. Access to naloxone is part of the training group by peers. Peers is what is the most important part of it here. We want to show that it is feasible, that it's accessible, and that's already been done. And so first responders, like the emergency crews, ambulance, and so on, will be able to have naloxone on them and know how to react. There is a two-part training program. The short training one is 2 hours, 30 minutes, and a longer one is 5 hours, 30 minutes, divided in the following way. The first workshop is prevention and education linked to overdoses. Workshop 2 is how to react in front of an overdose, recognize the signs of an overdose for opioids or other drugs, techniques that to bring people around again, reanimation, and proper use of naloxone. Who are the partners? Well, the partners are, of course, users, and we also have people who in the past have consumed opioids or are still using, people who are using other types of drugs or have used them in the past, and the staff that works with these people are familiar with what they are doing. So really, we operate our network very, very close to the street. There are people who have consumed opioids in the past and or other drugs. The people who work as resources are persons who, as I have said, were users in the past, either of opioids or other drugs. Resource persons, of course, might or might not be users still. Why? Because in community groups, the drug users will be there. They will work at a certain level in the program, and they will become integrated in the working network. But they might be users who are actually working as employees at the community level. And then again, we have to train them as to how to use naloxone in an overdose situation. So, to conclude, Profan is a community response to the situation. It was set up in 2013. I, in my work, looked at overdoses. I saw overdoses everywhere I went in Canada and Europe, and I was led to understand that there was a phenomenon that was developing. I set up the action plan of the organization to create an educational tool, and I've just described that educational tool to you. In 2014, the partners got together, Le Can, the Douglas Hospital, Narcoman, and other health institutions in Quebec. And from the very outset, we involved the peers. We brought in people who were familiar with the subject and even others who were not. So we brought them in for that first year, looking to work together, and now we're looking forward to our third year of activity. Since we undertook the program some 18 months ago, 378 persons have been trained and 21 lives have been saved. We are observing a change in behavior of users who have been trained in this matter. We have Mr. Michel Perrault, who is attached to the Douglas Hospital Research Center, who is working to evaluate the results of what we are doing. So it's being evaluated as a project per se. We want to see what the retention rate is for people once they've been trained, and what is the capacity of people to follow through once they have been trained in how to respond to overdoses. We are people who are there, and we feel our mandate is one of saving lives, saving people, but it's a beginning also of behavioral change that we are seeking to implement. You might think that what I'm talking about is rather here, there, and everywhere, rather disparate, but it has to be painted in broad strokes. And we would like to be able to see similar programs to Profan being set up everywhere if it were possible. It's something that would be very helpful. We want to be able to train the population in terms of substitution. We know that people are going to fall back, start using again, have overdoses. So we want to train people to understand that they can get methadone, and we want to train people in what to do if they, backslide and start using again. As far as its use for pain, we feel that there should be a naloxone kit widely available so that they don't have to dip into mommy or daddy's medicine chest. We have to heighten awareness as to how to use the naloxone kit. That will save lives. Once you train people, they can react more quickly. It's just the way of looking at pharmaceuticals in the home. That's something that can be important, and what you do want as well is to have at hand naloxone kit, and know that painkillers that have been prescribed for mommy or daddy are there. Now, we want to provide a short but well-adapted training. We go downtown Montreal, and we have contact with the dealers, with the sellers of the opioids, and with the users. We want to be able to train these people and give them short-term training so that they can have a permit to get naloxone. In Quebec, the management of naloxone is done in a certain way. In Montreal, we have to have a collective script. That means that people that covers the user, it covers the user's family, it covers the parents, mommy or daddy, as I was saying, the friends, anybody that is part of the entourage of the user. They can be able to intervene, like at, say, Chez Nous or at Cactus. This is, in a nutshell, what we do. In 2013, we set it down in writing. In 2014, we joined up with Le Grand. There was a wave of overdoses in the spring of 2014 in Montreal, and we were called upon to facilitate our project. In Montreal, currently, how can I say this? We don't have a broad epidemic with respect to fentanyl or the other drugs, contraband drugs that are made in labs. But we know that there is a lab in Montreal that was shut down about a year and a half ago that was making fentanyl. You know, there are always too many overdoses. Even one is too many, and we can't be complacent. We have to be ready in Quebec.
Wood. Good morning, Dr. Wood, Professor of Medicine at UBC. If you'd like to make your 10% or your 10-minute presentation, we'll be pleased to hear it.
Okay, good morning. Thank you for the opportunity to speak. My name is Evan Wood. I'm a professor of medicine at the University of British Columbia, where I hold a Tier 1 Canada Research Chair. I'm also an addiction medicine physician and medical director for addiction services at Vancouver Coastal Health. As you are aware, the costs of substance use in Canada are substantial and estimated to be over $40 billion annually. This is, of course, before the opioid crisis emerged. I think you'll be very familiar with some of the interventions that are required in terms of addressing the opioid crisis, but I thought I would take a moment to share with you some of the structural reasons that this problem has emerged and some of the structural barriers to fully and effectively addressing this. So the first issue that I think Canada can really pursue to the betterment of public health and public safety in exploring this challenge is the fact that we have not traditionally in Canada, as in other jurisdictions, trained healthcare providers in addiction care. So I'll just ask you to imagine a scenario of somebody having an acute medical condition like a heart attack. They would be taken into an acute care environment. They would be seen by a medical team with expertise in cardiology. The cardiovascular team would then look to guidelines and standards to diagnose the condition and to effectively treat it. Unfortunately, in Canada, because we haven't traditionally trained healthcare providers in addiction medicine, not only do we have healthcare providers who don't know what to do, but they're routinely doing things that actually put patients at risk. So the origins of the opioid epidemic in Canada, when it comes to prescription opioids like OxyContin, clearly there has been the exploitation of a knowledge gap leading to unsafe prescribing, and of course the failure to employ evidence-based treatments for alcohol and drug addiction suffers from this concern as well. In addition to the lack of training for healthcare providers, the overall lack of investment in this area has meant that there aren't standards and guidelines for the treatment of addiction. So in British Columbia, the long-standing approach to treatment of opioid addiction has been the use of methadone maintenance therapy. That approach has been disconnected from recovery-oriented systems of care and has overlooked a much safer medication in the form of buprenorphine naloxone. So in British Columbia, within Vancouver Coastal Health, we have recently developed a guideline for the treatment of opioid addiction using an evidence-based medicine approach to look at what treatment should be first line, second line, third line, as best ways to help people recover from opioid addiction. This is something we're looking to pursue nationally through the Canadian Research Initiative on Substance Misuse, which I'm happy to talk about shortly. Another structural barrier which I want to flag for you is that in Canada, we have increasingly lumped together the concepts of mental health and addiction. And while we have large mental health challenges in this country, and I certainly support approaches to strengthen a system of care for people struggling with mental illness, when we look at addiction through the lens of mental health, it results in a number of concerns. The first is that funding for mental health and substance use, when it's directed in that way, overwhelmingly goes towards other mental health conditions other than substance use, and addiction really is one of Canada's most serious neglected diseases. And I strongly encourage you to think about funding and support that's aimed at addressing substance use being clearly earmarked for that. Otherwise, it regularly goes into this sort of mental health and substance use black hole, and addiction is overlooked. There are tangible ways of focusing energy here, which I can talk about shortly, but certainly focusing on mental health and substance use has unintended consequences. And of course, there are individuals who struggle with both mental health and substance use, but your average person who becomes addicted, whether it be tobacco or alcohol or opioids, shouldn't be thought of as a mentally ill person, and the interventions that they commonly receive are more tailored towards people with serious mental illness and can actually worsen the overdose crisis. So I give for you an example: benzodiazepine medications that people with anxiety traditionally have been prescribed. Individuals with addiction regularly are prescribed these medications, again due to lack of physician training, and these medications themselves are associated with increased risk of fatal overdose. Something that's also needed, and you would have seen, I anticipate, the report that was released earlier this week on the need for prescription monitoring programs. British Columbia actually has one of the nation's leading monitoring programs to look at prescriptions being provided by physicians. It enables us to look at the patient in front of us and see what prescriptions have been filled, to address issues of people getting multiple prescriptions, selling medications on the street, and these types of concerns. But even in British Columbia, it's a reactive approach, and there is the ability to establish monitoring programs where colleges of physicians and surgeons could actually look for unsafe prescribing and routinely address that concern, and it's certainly something that needs to be done in Canada. A point that I think needs to be made is that we continue to overwhelmingly treat substance use and addiction as a criminal justice issue, and ultimately that worsens public health and safety. Of course, we need to support law enforcement due to the intersection between drug use and crime, but we really need to look at solutions that are evidence-based, that support addiction treatment, and that can support people in their recovery, rather than approaches that reinforce stigma and ultimately worsen community health and safety. A couple of takeaway points that I'll leave with you, and then I'm happy to take any questions. Again, the training of healthcare providers. The College of Physicians and Surgeons and the College of Family Physicians are currently pursuing these strategies. I certainly encourage you to support this. A point I didn't make earlier, which I think really I'll leave with you, is that addiction is much too common a disease to be left with specialist physicians, and we should really be looking to family practitioners being adequately trained in the prevention and treatment of addiction. Again, the focus on addiction as a disease that's both preventable and treatable, and not kind of getting lost in this sort of muddy mix of mental health and addiction. And I would use as an example as something that the Canadian Institutes of Health Research could do, for instance, in terms of dedicated resources towards substance use. In the United States, there is a dedicated institute focused on drug use, the National Institute on Drug Abuse. CIHR has no such institute, and it means that Canada is kind of punching in the dark when it comes to approaches to substance use. Certainly through the Canadian Research Initiative on Substance Misuse, which is CIHR funded, there are positive things happening, but certainly we could do much more with focused intervention. As I alluded to, prescription monitoring programs have a huge opportunity to reduce unsafe prescribing and the issues that emerged with OxyContin, ensuring that those don't happen again. We obviously need strategies for the safe treatment of pain, and we are increasingly learning that in the context of chronic pain, opioids can be very dangerous for conditions that can be addressed with non-opioid medications. I think I'll leave it there and just reinforce the point that we improve community safety and public health by treating this as a health issue, and that certainly requires dedicated, focused, and energy, and that's obviously the point of your meeting today. So I'll stop there and thank you for the work that you do.
And thank you for the work you do and your contribution today. We'll be asking questions shortly, but first we're going to hear from Dr. Mark Ujinwala from Recovery Ottawa for a 10-minute opening statement, please.
Thank you very much for having me here and taking the time to be interested in this most important issue. I'm a physician. I'm an addiction medicine specialist. I'm ASAM certified in 1988. I've been in the addiction world for over 30 years in the assessment, intervention, treatment of addiction. I developed the Ontario Medical Association Physician Health Program in '95. I spent most of my career helping professionals and sending them primarily to the United States for treatment, primarily physicians and people who had a lot to lose. And that was in the 80s and 90s, and I can tell you in the 80s and 90s we had the gold standard treatment for addiction in probably, certainly in North America, and that's because we hooked into the United States. In Ontario, I can only speak for Ontario, in the 80s, 70s, 80s, and 90s, we could send people to the United States for comprehensive treatment at the Betty Ford Center, at the Talbot Center, at Hazelden. Didn't really matter. They went there, OHIP paid that, and then when they came back, they had aftercare, and we had an amazing program that helped many, many Canadians. And in the 90s, the government decided they were going to stop this practice. They were going to take the money, and they were going to develop treatment centers here in Ontario. And unfortunately, that didn't happen. And my observation has been that, in fact, the only thing that happened was they started closing psychiatric facilities, throwing those types of patients under the bus, unfortunately. They did not develop comprehensive treatment programs as they promised, and that was the start of the downfall of our crisis. I agree wholeheartedly with many of the comments that Dr. Wood made. The problem that we face here is that addiction, the real issue is not opiates. The real addiction is the inability of the present healthcare system to treat the disease of addiction. And addiction is a biopsychosocial illness that affects 10% and probably more if you include families, and is the most underfunded medical illness and in our society. The problem also is that it's a highly preventable and a highly treatable illness. It's very unfortunate that people don't see that. And when it affects your family or yourself, you can feel the pain and suffering, and you watch the tragedy unfold in front of you. Dr. Wood commented about cardiology. If you had chest pain, what would happen? I submit to you, if one of you was going blind in here right now, and I said, would you rather I give you a white cane, or would you rather I take you to the Eye Institute to see a retinal surgeon? I guess you would go to the retinal surgeon. So the problem that we face is the lack of knowledge and understanding of everybody, the society, physicians, people in general, the government especially, to understand what this disease is and how to treat it. And I run the addiction curriculum at the medical school here in Ottawa for the last 25 years. And we've been decreased from 25 hours of curriculum time down to 3 hours. People seemingly don't want to take this seriously, but at the same time, they want to talk about, like sensationalize fentanyl and all these other drugs. And it doesn't matter what you die from. If you die from a Glock or if you die from a rocket launcher, you're still dying from a gun. It doesn't really matter. The problem is that we have an issue here that's poorly understood, and I think it's people like yourselves that are taking the time to listen to this that could maybe change this, and that would be my hope. I started a opiate withdrawal management center here in Ottawa. We are self-funded. There's no government funding for this whatsoever. We started with nobody, no patients, and now we have 1,000 patients on Suboxone Methadone in Vanier. We have 7 doctors. And my observation has been that these people want help desperately. They're victimized, they're marginalized, they're diminished. They're the people that really are the lost souls of the world that we need to help desperately. I got a card the other day that I shared with you as a thank you card from one of my patients. Said, I just wanted you to know how much my life has changed because of you and your staff. I will be forever grateful for your services. Thank you so much for helping me become who I am today. And I think that's what keeps me going, despite the fact that there's no funding, there's no treatment. I sent somebody to a psychiatrist the other day, and some of you who live in Ottawa, this is the message I got back from the psychiatrist after waiting 6 months. Dear physician, due to the high number of referrals received, there is currently a 2-year wait to be seen. We are unable to accept your referral. So why don't you call the Royal Ottawa Hospital? So I call the Royal Ottawa Hospital, which is our CAMH here in Ottawa. And number one, if you don't have an OHIP card, you can't go in there. You can go to jail without an OHIP card, I can tell that, but you can't go into a hospital without an OHIP card. They will not see you. It doesn't matter if you have a needle coming out of your neck, they won't see you. It's a 1 to 3 month wait to see the doctor for an assessment, and then after that, it's upwards of 9 months before you can even get into any type of program. So you're looking at a year, and these people are desperate. They're injecting drugs upwards of $600 to $1,000 a day habit, and they don't have a job. So of course they have to get money every day. They have to prostitute. They have to sell drugs. They have to steal. The crime is unconscionable, and we're all part of that. So then I said, okay, I will call the Royal out. I'll call our detox center here in Ottawa, which is heavily funded. And guess what? It's not a medical detox. If you call there and say, what do I do if I'm in withdrawal from benzos or alcohol or opiates? They say, well, there's no doctor or nurse here. You'll have to go to the hospital. So then you call the hospital and they say, well, we can't help you. So you can't go to the Royal. There's no emergency department or psychiatric hospital. So you go to the emergency department at the general hospital or teaching hospital. And you say, where's the Department of Addiction? And they say, there isn't one. And then you say, okay, what should I do? Say, well, you wait over here while you're in serious withdrawal. And you wait 13 to 20 hours to see a first-year medical student or a resident who has, as Dr. Wood says, no training in addiction whatsoever. And basically, this is the case I had here. Went to the hospital, came in by ambulance unconscious, and I'll scribble like doctors. I can't read it really, but it says patient found unconscious at a bus station. They woke him up, and then the diagnosis intoxication, and then the disposition is follow-up with GP, which he doesn't have, for a refill on his pills. That's it. That's at a teaching hospital in our country. That is poor. And I do a lot of the teaching at the university, and I'm a Royal College examiner. If that's what you did on an exam, you'd fail. You can't let people who are dying leave a hospital. It's ridiculous. But that's what we do all the time, constantly, all day long. And so the answer, the smokescreen answer of the government appears to be, let's put up injection sites. And that will solve our problem. And give them a pamphlet, by the way. So here's the pamphlet they give you. And I've had several media sit with me for 4 hours. I said, let's go through this pamphlet. We'll call everybody and see if we can get help. And after 4 hours, they go, oh, my God, there's no help. Nobody will help you. You can't be on any treatment center on methadone or Suboxone. There's no medically assisted treatment. There's no physicians involved. There's nothing. So you got to fill forms out with a thing called ORS, like 12-page report. And what does that help you? You're dying of the disease, and you're filling reports. Imagine if you had crushing chest pain, and they told you have to fill a 12-page report out first, and then go stand over there for 13 hours. It wouldn't happen. So I feel ashamed as a physician and as an addiction physician in this province that this is what it's come to. It really, you can tell by my voice and by my enthusiasm, because I have 1,000 patients right now. Okay, 1,000. I deal every day. We try to help these people as best we can. We're integrating with the CAS. We're integrating with the parole boards. We're integrating with the jails. It's a bureaucratic nightmare, and this is a health problem that's highly treatable that we're doing nothing about, except saying, let's talk about carfentanil, let's talk about this fentanyl, let's talk about that fentanyl. It's like a group of people that don't know what they're talking about, or sensationalists followed by the media, rather than saying, we have a treatable illness, it's called addiction, and we should take the time to go back to the 1980s and see what we were doing back then when we didn't have this problem. We still had 10 to 20% of the people with the issues. However, we were treating them. So now, if you can't get a psychiatrist, you can't get an addiction doctor, you can't get treatment, what do you expect these people to do? Of course they're going to go around in the market. Hey, every person that you've seen in the news has been one of our patients. The girl that got stabbed the other day, she didn't get stabbed for fentanyl. She got stabbed because she cheated a guy on cocaine for $15. And the guy came back and he was high right in front of the shelter, and he stabbed and killed her. And the other guy that shot the other day, it was another drug-related thing. He was also our patient. These people need help. They're desperate. They're living in a war zone here that I can't even look. You can just go downtown and look. You can come with me. I'll show it to you. It's right here in Canada's capital. And it's shameful. And we as a group should take this opportunity to say we're all going to leave here and we're going to do something meaningful about this. We're not going to let these people die. So, thank you.
Well, thank you very, very much for your passion from all of you. And we're certainly getting the message, I would say. So we're going to start with questions now with Mr. Oliver.
Well, thank you very much to all three of you for excellent testimony and presenting your recommendations and thoughts for us. I just want to step back a little bit and review where we're at. certainly the government, this committee are highly concerned about the number of overdoses and deaths, particularly from opioids. And we've heard from many witnesses this is a public health crisis. It's not a criminal justice issue, and I've heard you echo that. The Minister of Health has laid out a comprehensive federal strategy, so better information for Canadians about the risk of opioids, supporting better prescribing practices, reducing easy access to unnecessary opioids, supporting better treatment options for patients, a better evidence base around this, allowing naloxone to be used and bring naloxone nasal spray in from the U.S., making some of the drugs that are used to produce fentanyl, some of the chemicals illegal. So I'm looking now, and there's going to be a summit in November to deal with the opioid crisis that I think the Minister of Health is convening. So trying to figure out what are the recommendations that we could add to that discussion from witnesses such as yourself. So from Dr. Wood, I heard pretty clearly training primary health care providers in addiction care and treatment strategies, establishing guidelines and practice standards so that there's a methodology to it, directed funding to addictions versus mental health and addictions, the online prescription database. Dr. Ujawala, I heard your, I'm trying to figure out what is the advice then? So I heard the gap. Is it that we don't have a proper diagnostic category for this? I mean, it's viewed as a there doesn't, so the person that was left, the emerged, there was no diagnosis. Do we need a DRG group?
Intoxication. It's like Dr. Wood and I are saying, they don't, if you don't know what you're doing, like you wouldn't want me being your retinal surgeon right now because I have no training for it.
Exactly. Yeah.
So you're going to die. If you put me, if anybody wants their appendix out right now, like I'm not the guy to do it. Okay? But if you want to get recovery, if you want to get your son who's addicted to fentanyl off and get back to normal, okay, I'm your guy, right? So where are all the addiction physicians? Where are all of Dr. Wood and I on all these committees that are trying to explain to hospital boards and everybody and the LIN and all these people that give them money? You know, you're talking about naloxone just as an example. Oh, there's no limit.
Get the gap.
Yeah.
How do we get that? Like, what's required? I mean, if there was a diagnosis that said addiction,
it won't matter.
It wouldn't change. Like, how do we get a focus on?
It's action. You need to develop a comprehensive treatment program for the treatment of addiction. Just go on the internet and Google Betty Ford Hazelden. It's the gold standard of treatment. You know, when people ask me this and say in 15 seconds, tell me how you're going to solve this problem. I mean, it's ridiculous. You need time to explain to you guys what this means. So if you go on that website, I can show you what it...
So federal leadership to say there needs to be... And Dr. Wood, would you add anything to this conversation around like how we... some specific recommendations we could make as a committee to Parliament around initiating these kind of practices?
Yeah, so I think a lot of consensus from in the room. I think through the College of Family Physicians federally, really ensuring that part of the curriculum includes the prevention and treatment of addiction. I don't want to bash specialists. I'm a specialist myself, but this disease is so common. It's not something rare like, rheumatoid arthritis or something that's relatively uncommon. This is 10% of the population, as you've heard. So we needed a primary care-based strategy to train physicians, because in the example that was given with the emergency room, they're saying intoxication, but they know exactly what's going on. It's just the healthcare system is a deer in the headlights. It does not know what to do. So training healthcare providers and developing evidence-based guidelines and standards. If somebody shows up at the emergency room, and just to give you an example, at St. Paul's Hospital in Vancouver, between January and August, there were 2,700 non-fatal overdoses that presented to the emergency room. And we know the literature clearly shows that people who have had had a non-fatal overdose are at heightened risk of a subsequent fatal overdose. So there's a very captive audience. You want to do something about it. There is no system. It's not a broken system. There is no system in place. So I don't want to make it seem so daunting that no one knows what to do. There should be standards in the emergency room and evidence-based pathways and referrals to programs, because I tell you, the Canadian taxpayer is hemorrhaging money to send ambulances, to send police, to treat the infections, to treat the lung disease, the liver disease, all of the things that go along with untreated addiction. So there's money to be saved, but it's training healthcare practitioners and establishing guidelines.
Thank you very much. I had one other line of questioning I wanted to get in here before my time runs out. So we haven't heard any advice or comment around pharma. So the introduction of OxyContin, the introduction of opioids, the prescribing, the initial sort of encouragement to prescribe these, or recommendation, I guess, to physicians to prescribe. Do you have any of you have any comment about the role of pharma in this, and any advice there?
I'm happy to speak to that. It's been well documented, and there's lawsuits for hundreds of millions of dollars in the United States because of the shenanigans of the makers of OxyContin to try to, as I alluded to, there was a void in physician knowledge, and this promotion of pain as a fifth vital sign and implying that OxyContin was safe and non-addictive, that's clearly not true, and the influence in the pharmaceutical industry on physicians had a hugely negative impact. So there's regulatory opportunity there too.
If I could add to that, in terms of, I think one of the reasons why I can't give you a specific recommendation is because it's so broken that like, where do we start kind of thing. But if I was saying, if you could go on the Betty Ford Hazelden website and present that to the federal government, say this is what we had in the 80s and 90s, 70s, 80s, and 90s, we need to open those doors up. And, you know, to Dr. Wood's point about the 2,700 people who came in with non-fatal overdoses, what a unique time to put them on Suboxone. Why would you not just put this guy here on Suboxone, send him to my clinic, and then get treatment? Like, simple. Bang, 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 done. But instead, they don't know what they're doing, and they're irritated by these people, and they spend, like he says, lots of the resources, dump them back to the street, then they get picked up by the police, back in jail. So that's the issue. And so we really, the message is you got to open the doors again. You can't have a 2-year waiting time for a psychiatrist. It's ridiculous. You can't have no treatment centers. It's ridiculous. You can't have no non-medical detox. It's ridiculous. This is 2016.
Time's up. Dr. Carey.
Thank you very much, Mr. Chair. I truly want to thank the witnesses here today, because one of the things I think we've been lacking in this study is really the front line. And I wanted to start off with Dr. Eugene Walla, because I think you're actually the first medical professional that we've had in front of committee here that actually works with every day with opioid-dependent individuals. I think you're the first one to appear at our committee, so thank you for your insight. And I want to thank you as well for your passion, because I think everybody around the table sees how committed you are. And how discouraged you are that all levels of government are not really taking the bull by the horns to deal with this. So I do want to thank you for your work, and I do have a few questions for you, because I see you as actually doing it. Nobody else that's come here is actually on the ground actually treating people. And I was wondering if you could elaborate on the kind of appropriate care that you would provide an opioid-dependent individual, in contrast to what's been brought up a lot here is these supervised or safe injection sites. And you made a comment just now about dumping them back on the street, you know, in and just dump back, dump back, dump back. Could you give us some advice on what appropriate care, like you're giving them today, you're helping people today. Could you elaborate on that?
Well, it's similar to Mr. Oliver's question about, you know, what would you present to the provincial federal government on how do you treat the disease of addiction. I think like anything, as physicians, we're evidence-based, and so what we're saying is that we have to utilize resources or processes that help people. And I think as a doctor of 30 years, I'm trained to help people. I'm trained to treat treatable illnesses. Hey, you know, if you have a palliative care patient and they're going to die, and my father died in a palliative care unit, so I know what that's like, he wasn't coming back. So yes, he had lots of opiates, and that was fine because he had bone pain. But he was going to die. But when you have a 26-year-old who, like 2 years ago, was on the McGill soccer team and now is homeless and injecting heroin and smoking crack, and 2 years ago she lived, you know, in Westmount, like, that's a different story. So this is a person that we could help. So how would you help them? Well, you'd have to deal with, from a medical detox point of view, depending if it's alcohol or benzodiazepines or opiates, amphetamines, it doesn't really matter. You have to develop a comprehensive plan to say we're going to deal with each of these issues, and you're going to have to do that properly. And unfortunately, you can't do that in 10 minutes, and it requires hospitalization often to be able to take the time to investigate it, to understand the biopsychosocial element of this woman, to treat her withdrawal properly. If you have to, for us in the opiate world, Suboxone and methadone have been godsends, because you think about it, if you're stealing up to $1,000 a day to get your fentanyl patch, the crime, and like, think about that. In February, you're 26-year-old and you got to get $800 today, and it's 8 o'clock in the morning, and you're in horrible withdrawal. You know, and I always talk to people about the withdrawal of opiates is like Norwalk virus and a panic attack at the same time. It's just horrible. They'll do anything. So, you know, so we have to deal with that withdrawal, and Suboxone and methadone work very, very well for that. It's not the treatment. It's just it's a transitioning away from, you know, that horrible existence that you've developed of acquiring pharmaceuticals or heroin, and into a place where you're now stable enough to deal with your life. And then that's the next part of it. And that's what, if you go into an actual treatment center, whether it's Bellwood, Homewood, any of these places, then they start dealing with life. And it's the thinking process, the problem. We get focused on the behavior, i.e. using the drug, which is, they're using that to deal with all their problems. They like to use that because that makes them feel normal. The problem is the consequences of using is the issue. And so what we need to do is then look at the person's physical problems, the person's emotional problems, the person's psychological problems, career, money, family, all that stuff. And again, for 25 years, I sent professionals, physicians, lots of politicians to treatment in the U.S., and they stayed down there for 3 months, and when they came back, they were really in excellent position and maintained sobriety. So it would be trying to help you guys understand what a comprehensive treatment program looked like, and then you could explain that to the rest of the world.
Well, that, and I can see a holistic approach working, but we've had a lot of witnesses just say, like, these safe injection sites are the solution, and I see that as kind of giving up on people, just throwing them back into what they've been doing day in and day out. And I was wondering if you could share the success of the recovery center that you have, because
Right.
do you do safe injection sites?
Okay, so first off, I mean, I'm sure you've heard a lot about this injection site thing. First off, the word safe it's a marketing thing, because if I had a needle right now full of fentanyl, would anybody volunteer let me stick it in your neck? Like, I doubt it, because it's not a safe thing to put a needle into your neck full of fentanyl. So, and then the word supervise, the idea, I think, came out of their issue and Dr. Wood, I'm sure, can speak to this, in the Upper East Side of Vancouver. You know, fair enough, it's a public health, HIV, Hep C issue. It's not really an addiction issue, in my opinion. It's really, the government's missed it. It's almost like a smokescreen to say, if we do this, we don't have to do this comprehensive program, which would cost billions versus maybe $500,000 for the injection site. So my experience has been that if I had an opportunity to get better, why wouldn't I take that? You know, one of the analogies I use is, if, let's say, I'm a lifeguard and somebody's drowning, and I finally get them out and do CPR and they're alive again, and then I just throw them back in the water. Like, why would I do that? I've got them here now, and let's treat them because it's a treatable illness. The problem, I think, is that the door's closed everywhere, So it's like this has become a quote-unquote treatment option when instead it's just an idea that homeless people could go to this place and I guess somebody would wake them up if they stop breathing. The thing is that we have in Ottawa alone probably 3,000 to 4,000 people injecting at home every day, and they inject 5 to 8 times a day. It's about 30,000 injections a day. So you don't see everybody dying from it. And my main point with the treatment aspect is, if you're this woman who is homeless, who's Hep C positive, who's hasn't eaten, who's just ravaged with illness and addiction and depression and mental, and has to wake up every morning to turn a trick to get money, do you really think she wants to wake up in the morning? Like, that is no life. That is living hell. And I have some pictures that I could show you. If I show you their faces, that is living hell. They don't want to do this. And if I gave them an option, if there was another door, which there isn't, that's the problem. That's my whole point of telling you all this stuff. There isn't another door. So I opened that door because I saw a need, and we have 1,000 people within 3 years and 7 physicians within 3 years working flat out all day long trying to keep people out of withdrawal. Our problem is we don't have the next step. We don't have any funding for any kind of psychological help, any kind of treatment programs. There's just roadblocks and barriers everywhere. So it almost seems like there's this conspiracy not to treat addiction and to say, listen, this is the answer. You can come into our little basement thing, inject, we'll give you a pamphlet, bye-bye. And that will be the answer for the treatment of addiction. And I don't think as Canadians that we believe that. And I know a lot of really wonderful people who are supportive of a foundation that I'm going to try to start to privatize this, to develop our own centers, because if the government's not going to do it, I think we're going to have to do it, because I just can't stand here and watch these people die every day and suffer.
Time's up. Ms. Kwan.
Thank you very much, Mr. Chair, and I thank all the witnesses for their presentation. My question is to Dr. Evan Wood. In the 1990s, in my community, the downtown east side, where we've had an epidemic of overdoses, at that time, the medical health officer declared a medical health emergency in our neighborhood. And the truth of the matter is that people die from overdoses. We had a community rally with some 1,000 crosses planted in a local neighborhood park to mark and honor each person who died. And so I get it that we need to have treatment, and in coming out of that effort, a table was initiated with all levels of government. I see Dr. Harry Fry here today at committee, where we work together between all levels of government to come up with the 4 pillars approach: the harm reduction, treatment, prevention, and enforcement. 4 pillars. And coming out of that, the harm reduction pillar was the supervised injection facility. Evidence-based, since that time, that facility has demonstrated that there was no fatal overdose deaths in that site. And hence, those opportunities for people to get onto, hopefully, treatment and an alternate course down the road. Supervised injection facility in Vancouver. Can you tell us, Dr. Wood, has it been an effective program? And as I understand, there's also a place called On-Site upstairs from the supervised injection facility. I wonder if you can elaborate on that, and then to talk about then the critical link that is required following On-Site and what's missing.
Yeah, my biggest philosophical comment would be how counterproductive it can be to pit sort of public health interventions against medical treatment and recovery interventions, because they don't need to be sort of viewed in opposition or isolated interventions. I'm very sympathetic to my colleagues' frustration with the sort of attention being given to public health interventions when the treatment system has yet to be developed. We need a comprehensive approach. In the absence of that, as I alluded to, we are hemorrhaging healthcare dollars. Each and every case of HIV infection addiction on average costs the healthcare system about $500,000. The amount of money that gets spent looking after somebody who has had a hypoxic brain injury and will now, because of that brain injury, have to be institutionalized for the rest of their life and cared for at the expense of the taxpayer. Hepatitis C, the prevalence of chronic hepatitis C infection, upwards of 70% among people who inject drugs. The pills to treat hepatitis C are about $1,000 per pill. So not just the fact that people are dying and government should be responding, but these are huge healthcare costs. In terms of addressing those costs, Insight has been shown to reduce overdoses and has been shown to reduce syringe sharing and other risk behavior. So of course I support it, and I think everybody should, because we already have programs across Canada, just by example, that in an effort to mitigate these harms and costs, we give out clean needles to people. But a program like Insight actually is I would call a more conservative approach, in that it allows the healthcare system to ensure that that needle doesn't end up in a park, that the young people don't see that person injecting, that intervention is delivered in an environment where that person can be encouraged into treatment such that it is. So unfortunately, and I know this is a huge source of frustration among my addiction medicine colleagues, is that you see injection sites in the news and it implies that the taxpayer is investing a great deal here. I'll just share with you, Vancouver Coastal Health, of which I'm the medical director for addiction services, spends hundreds of millions of dollars every year on mental health. They spend an almost insignificant amount, less than a sixth of that, on addiction, and a minuscule amount of that, like really inconsequential amount, on supervised injecting, which then saves the taxpayers a huge amount of money. Among the things that it is able to do is it has a detox program upstairs called On-Site that can take individuals and help them through detox and transition them to treatment. They're very effective in doing so. And I just strongly encourage people that want to pit one of these things against another. It really is nonsensical. We need a comprehensive approach. We need an addiction system of care that can meet people where they're at. And these low threshold programs are very effective in that we need the door to addiction treatment and recovery. But that door, the literature from Europe would suggest, is meeting people where they're at. And to be honest, these interventions are associated with reduced rates of injecting in the community. And so I think a public health approach I certainly support, and it's been effective in Vancouver. If there's been any mistake made, it's been the lack of emphasis on addiction treatment going back to the 1990s, and that's something that we're trying to dig ourselves out of now in terms of some of the interventions I talked about, training healthcare providers, developing standards and guidelines, but certainly the supervised injecting facility from an evidence-based medicine perspective has been effective. We need a more comprehensive approach, obviously.
Thank you. Just to follow up on that then, so it's clear that supervised injection facilities, harm reduction approaches save lives, and it also addresses a whole range of other community impact issues as well. And when you speak to the issue around treatment, On-Site provides for that support, but then coming out of On-Site, though, I know this to be a problem in my own community, where people actually don't have better alternatives to go to. Often, I think other longer-term treatment options are not available, and so hence you do create quite a challenge within the system, and people can get into a situation where there's a revolving door. So with that in mind, in terms of the next phase of what needs to be done, I wonder if, Dr. Wood, you can elaborate on that. And in the meantime, as we are faced with yet another crisis with the fentanyl usage, where deaths are occurring in our communities, not just in my community, but throughout the country. And I wonder if, Dr. Wood, you can comment on Bill C-2, and whether or not that bill should be repealed.
Yeah, so in terms of your first question, On-Site is located in the downtown east side, so you're exactly right. It's a place where people in crisis who really are, their lives are a living hell, see the opportunity for something else. They get a bed, but then what next? Obviously, we'd want to get people out of the downtown east side, and investment in recovery-oriented systems of care have not been there. So unless you have, $20,000 to go into a expensive treatment program, the door just isn't there. Long wait lists. It makes absolutely no sense. I'm not a lawyer, and I don't want things to get politicized in terms of C2. I just think there's been a lot of misinformation, and I've seen how when these things become oppositional, people get entrenched in their thinking, and they put their blinders on, and they don't understand that by focusing on preventing sort of public health interventions, it doesn't achieve the objective of another thing coming forward. I just haven't seen that, and I just strongly encourage everybody to try and get beyond historical partisan issues around this crisis and to focus on what's best, and clearly that's going to be an evidence-based approach. It was alluded to that it's going to cost a lot of money, but I just reiterate the point: we're spending that money. We're spending it on emergency rooms, on HIV and hepatitis C wards, on programs for people who've had hypoxic brain injuries, the cost to productivity, and of course the cost to families who have lost a loved one. The money is being spent on downstream consequences, and if we can reduce those costs through public health programs that are proven effective, of course I support that, but we need a more comprehensive approach in addition to that involves an effective treatment system, and training healthcare providers and establishing guidelines and best practices is a clear way to identify where those investments should be and move forward.
Mr. Ayoub.
Merci, Monsieur le Président.
Thank you, Chair. And thank you to all three of our witnesses for being here today. This morning, well, for me in particular, I am not a doctor, but it is a wake-up call, as you say in English. I've taken notes to try to understand. I've got doctors all around me here, but I've taken notes to see how the medical dimension can be addressed. But I would like to address another dimension. I've had 50 years of being a human being. My experience of being an imperfect human being, Doctor, can I ask you, are all classes of society affected by addiction? There are no walls, no parameters. Dr. Ujiwa, am I correct? Well then, is there a certain class of people who perhaps have been less lucky in life, who have had less support in life, who get involved in a cycle of addiction, of lack of solutions because they don't have family support, they don't have societal support? Is that what you have witnessed in all your years of practice in this area?
Yes, I believe that addiction, like any other disease that we face in medicine, crosses all the borders. If you're diabetic, it doesn't really matter what your income is. So I think that in a general sense, addiction encompassing, the use of substance abuse, including alcohol and other drugs, affects everybody. And for 25 years, I told you, I only dealt with people, professionals only. So every quote-unquote person suffering from addiction was either an MP, an MPP, a physician, a lawyer, an accountant, a dentist, a pharmacist. So that was one element, and I know I can tell you firsthand, I treated, hundreds in terms of the people that we see, unfortunately, in the opiate and cocaine world, amphetamine world, the consequences of the use of their drug. Like, they may start the drug for, believe it or not, I have 2 professional hockey players as patients who injured themselves playing hockey, and just regular guys who broke their arm. And now they went from bad to worse, and this happens to many people when they get dependent on the drug.
7 minutes.
Yeah, okay.
Or so I need
So the
to-
point I answer is yes.
Yeah, okay. I expected the answer.
Yes, Mr. President, I have a comment. I would like to do it before I have to go. I have to leave, and there might not be questions from me. So I'd like to comment on what's being said, if I can.
Yes.
Yes. Okay. First, I want to say something that I came here with an approach to react to overdose. But also, I didn't mention that in our facility, we have a drop-in center with peers and community workers, and we also have apartments. We reach out to people that are homeless, and we try to bring them to treatment and also into a program which is running over 3 years with the plan of action to change. That's one thing we do. And the other thing is, when we're talking about a safe injection site, it would be a big approach for Canadians to talk about consumption room, so that way you don't have only people with needles in those places, but people that do smoke crack and use the other substance. It is also a reaction to different things that bother the society, downtown Vancouver or downtown Montreal or here in Ottawa. So it's a reaction. Treatment is also a reaction. Naloxone is also a reaction. I think it's very important that we start educating our youngs as soon as possible, starting from the lower grade, and with an approach of harm reduction, not with an approach of prohibition. It is the worst thing to do. It makes it tempting for people to use. Also, I want to say that all users are not always in the streets. They also live in houses. And I want to say also that people that are using drugs are getting more and more bad in their condition if their condition of life is bad. So if you don't have proper work, proper money income, and you're staying not in proper environmental place, and you don't eat properly, you will go towards down very fast. So it's very important to understand that if you have a capacity to sustain yourself in a good quality of life, you might not end up downtown. You might run your addiction many years before you seek for treatment. So, from my experience, not all user wants to go into treatment. Some don't see themselves as sick people. So it's very important to consider that also when you do an action to implement programs in Canada. Thank you.
Thank you very much, and thank you for coming. I know you have to leave early, and we appreciate your contribution today.
Thank you.
And Mr. Ayub, you still have 3 minutes and 24 seconds.
Mr. Chair?
Yes, Mr.
Just a point of order here. Mr. Lebec, are you leaving right now?
I can have a few minutes more.
Okay, I think I'm up next, am I not?
You are.
Okay, so if you can, I just have a couple questions for you. So,
Go ahead.
Okay, thank you.
Mr. Ayub, carry on.
Merci, Monsieur le Président.
Thank you very much, Chair. I'll move along more quickly then. What I was getting at in all this is that with 25, 30 years of practice in your field, here we are 25 years later with, I think, the same problem. The same problem or even a worse problem, because the Band-Aid solution that was applied 20 years ago, 15 years ago is no longer working. So what's happening is that there are leaks being sprung, and we're trying to staunch the leak. In a word, what are we waiting for to have the Betty Ford Center that you spoke about, Dr. Ndwala? Why don't we have that? Everything that you've done over the decades. I've only been here as a member for about a year. I'm very happy to be here. But over 25 years, and you see what has not been done over 25 years, you have to ask yourself why. Maybe I understand what the answer is, or at least a part of it. Is less costly to come up with a Band-Aid solution that will be short-term rather than to really try to correct the problem. And Mr. Levesque, I think you're part of the Band-Aid. It's not to judge your intervention. Your intervention is very important. Intervention saves lives, but it doesn't settle a problem. Am I wrong in my thinking? You talked about the lifeguard that throws somebody they've saved back into the sea. Well, here you're facing dangers. You try to get persons out of danger, and then the solution is not found. So this whole notion, there's the money dimension. What should the government recommend? I'm going to give you a minute to answer because I just probably have about a minute left.
I mean, I throw it back to the politicians here. You tell me why it's not happening. It was good, and now it's gone. So that's the question, and it's a rhetorical one, and I appreciate your comment. I think that if the will is there, if the people are wanting to help these individuals, then you can do it. If you don't see it as a problem and you don't live it or you don't understand it, then how are you going to develop a comprehensive treatment program as we're talking about? And so I think that that's the job of this committee, I think, to make Canadians aware of what the disease of addiction is and all the different components of that, the public health components and all other things that Mr. Levesque was talking about, so that we don't see it as a Band-Aid. But I agree with my colleague, we don't want to be fighting public health against addiction medicine, against specialists, against social workers, we need to work as a team. And I find what's changed now is that we're not working as a team. It's so regionalized, there's so much bureaucracy in it, everybody's worried about their jobs and stuff, and people have ideas, okay, I'm a harm reduction guy, it's like the Leafs against the Habs. I'm a harm reduction guy against a treatment guy. And that's ridiculous. And so I think what we need to do is work together and realize that there's different stratas and there's different, just like in all medicine, some people need to be in an ICU and some people can be treated as an outpatient. The problem is, and why I brought these things in, what we presently have, if you want to see a psychiatrist, 2 years to see one. Okay, how's that going to work? You want to see an addiction doctor, there isn't one. So how's that going to work? You can't get into the psychiatric hospital. So that's my point only, is that if we open these doors again like they used to be in the 70s and 80s, we can be proud of that system and we can develop it. It's not complicated. It's just the ability to say the political will's there, the will of the, of the Canadians are there to change this.
Thanks very much. Time's up. Now that completes our 7-minute session. Now we'll go to the 5-minute session, and the speakers will be Mr. Weber, Dr. Ayolson, Dr. Carey, and Dr. Fry. So, Mr. Weber, your floor is yours.
Thank you, Mr. Chair. And thank you, Mr. Levesque, for sticking around. I appreciate that. I just want to talk a little bit about your facility and where you are at Protan. How difficult is it for you to get the antidote, naloxone?
Actually, we have naloxone because we have what we call a collective prescription from Dr. Massé from the Département de Santé Publique de Montréal. Okay, this is under the condition we were able to have this naloxone. It's vials and injections. It's a kit that has everything in it that you need. And to get it, people have to take the training, actually at this time. When the legislation will be done, it might change, but...
So when you say you go through this two-part training that you explained, and that there's even a shorter-term training that you can train dealers, so then once they get this training, although I find it difficult to understand how you can train an addict in a 5-hour course how to put naloxone in its system.
We do it. What we do is first we know people that are using. What they do is they're hustling for money. That's one thing. So we give out a compensation amount. Let's say if it's a short training, it's $25, and if it's for the whole day, it's $50. So that way we know the person can manage to get their drugs if she needs so.
Those drugs from you, you hand them out to the user.
We don't give out drugs.
Okay, the naloxone is what I'm
The
referring to.
naloxone is into a community group of pharmacists.
Yes.
Okay, and they are designed. So you can have, I think there's 5 of them.
Yes, yeah.
And people can come out from our facility with a card. We issue a card,
Yes.
competency card, and they go to the pharmacy and they get the
see.
naloxone.
Okay.
That's how
all
it's
right.
being done.
And then cost-wise, who pays for that?
Well, at this moment, it's paid through Département de Santé Publique. So it's a ministry.
Okay.
It was a trial for the first year, and we've
Okay.
put the result
Yeah.
second year, now on the third year.
All right. Now, you're also a safe injection site as well?
No. We
okay.
don't carry
All
safe
right.
injection
Okay.
sites.
Well, then-
People can use in our facility. It's there.
Yes.
We have a supervision
Okay.
training, and we're able to answer to those.
Do you have equipment there in order to test the drug? to
No,
see if
we
it's
can't
safe?
test the drug right
Okay.
now because
All right.
we could arrest it being.
I see. Yes, exactly.
Holding
Well,
the
I'm going to
drugs.
quickly jump over to Dr. Wood here. Dr. Wood, of course, you've been to Insight and On-Site. You worked in British Columbia. I just a stat here I want to put out here. In 2015, Dr. Wood, there were 263,000, over 263,000 visits to Insight. And of those 263,000, 464 were referred to on-site, the actual treatment, in order to, get further help. That's only 7%, and I find that quite surprising that it's so low. Can you comment on that at all?
Yeah, I'm happy to. First of all, the number of injections are not unique individuals. So Insight isn't for everybody. The people that use it tend to be homeless, street entrenched, and live within a couple of blocks. So in the downtown east side, it's estimated there's only about 4,700 people who inject drugs. On-site has 12 beds. So to answer your question, as I think you've heard, the door to a functioning addiction treatment system is not there. So many people have successfully entered into recovery through on-site, but view it as sort of a crack in the door to a whole other reality that simply has not been invested in. So Insight has saved lives, it saved the healthcare system money, but we haven't realized the opportunity to address this concern comprehensively because there hasn't been an investment in addiction treatment in accordance with the scale of the problem. The money has gone to the consequences of addiction.
Okay. All right. Quickly, do you have the equipment there at on-site, Insight, in order to test the drug that they bring in for safe injection?
No, and I think that would help. I think that would help if we addressed regulatory issues there, because we've seen this shift towards fentanyl, which the average patient of mine is not looking for fentanyl. Fentanyl is a market force. People with a background in economics can understand it's cheaper, it can be imported, it doesn't have to be grown with a poppy. So it's a market force because of the longstanding illegality of these drugs and organized crime seeing an opportunity in exploiting it. And the market could be influenced through drug testing.
Time's up. Thanks. Dr. Elson.
All right. Thank you, Mr. Chair. Thank you both for coming, and thanks in absentia to Mr. Levesque for coming. I appreciate both your comments very much. Dr. Ujinwala, I practiced emergency medicine for almost 20 years in Winnipeg, much of it at the major teaching hospital downtown. I could not agree with you more that during my training, we did not receive nearly enough training in addiction. The only addiction training I received in medical school was a 2-hour instruction on what to do if one of your own colleagues is addicted. So I knew what number to call if I found out one of my colleagues was addicted to drugs. And that was pretty much all I learned in medical school. I learned more in residency because I did a 5-year emergency residency. Most of what I learned about treating addiction was the fortunate coincidence that some of our physicians were part-time emergency physicians, part-time addiction specialists. And I learned a lot. I learned most of my addiction medicine from them during shifts, just during conversations. Not a well-structured way to learn a very important topic. And I agree, we don't have the proper facilities we need. Family doctors don't know what to do. They send them to us. And people come to the hospital expecting to be admitted for their morphine or their fentanyl addiction. And we tell them, we have no place to admit you. We don't have a program to admit you. Internal medicine won't admit you. We can't keep you in our emergency department. We can give you a prescription for clonidine and give you a referral, which is going to take weeks to months. And that's all we have. I initially disagreed, Dr. Ujinwala, about what you had said about harm reduction, but maybe I misunderstood. I think we would both come to the agreement that it's not the only way, the only pillar of treatment. If you had nothing but safe consumption sites for drugs and nothing else, then you're not addressing the problem. I think you and I would both agree with that. But when we talk about it being a Band-Aid solution, and I said these exact words in an earlier meeting, when I'm in the emergency department and someone is bleeding, they need the Band-Aid. When someone comes in stabbed, yes, they shouldn't have been stabbed and that should have been prevented. But they're stabbed, they're bleeding. Would you not agree there's a role for it in saving lives, improving outcomes, but in addition is needed more investment in addiction?
Sorry, a role for what?
A role for centers like harm reduction sites, supervised consumption sites, as one of the aspects. As a short-term treatment,
it's such a small, such a small, minuscule part of what we do. I agree with my colleague. There's only, for example, in Ottawa, there would only be probably 20 to 40 homeless people that would come from the shelter on Nelson Street over there. That's about it. And I deal with people all across Ottawa. Nobody's going to get on a bus in February from Orleans and drive down there to inject. So,
I agree with you on that, and that's why I'm saying it's. And I agree, it's a small part of
and that's
huge
fine.
problem.
But to your point, I was an emergency physician in a small community for 10 years.
Yeah.
And we had no specialists. So when somebody had a fractured femur, I'd put an IV in, splint them, and then I'd call the ortho guy in North Bay.
Yeah.
Okay. So the difference here is you guys aren't calling Dr. Wood and Dr. Ujinwala, and it would be so easy to implement a program that emergency doctors, they call the addiction guy, they put them on Suboxone, they send them to my clinic the next day, and then we get them into treatment with some counselors that the government pays for. That's it. It would happen so fast. What we're missing is that piece, because the emerge doctors aren't doing that.
Yeah.
They're missing a unique opportunity, and they see them as drug seekers.
Well, see, I can say in at least from our experience in Manitoba, we want to do that.
Okay.
In Manitoba, we don't have anything like that. I do not have anyone that I can call that they can see in the next few days and have them on Suboxone.
Are you sure?
I am positive. Yeah, it's been. I spent the last 8 years in the hospital where everyone comes to it.
Well, we need to develop that.
I agree completely. What I can do is put them on things like, Suboxone is fairly new. We've been using clonidine with reasonable effect. We refer them to these, we call these people and they say, yeah, put them on our list. We'll get back to them and there isn't someone like you that I can send them to right away. I would love to have that. We want that. We've been advocating for it. And I'm glad to hear you being here today to tell us how badly we need that.
And to your point, if you Google Suboxone New York, Suboxone California, you're not even going to believe what you see, the thousands of physicians that do this.
Yeah.
So to the point of developing these guys, it wouldn't be hard. The buy-in just hasn't been here in Canada for some reason on Suboxone. Like when I traded on Suboxone in Chicago, every doctor, every emerge guy was doing it. So that's actually would be pretty simple to do and would save all the emerge guys. You don't want to deal with all that. You want to put them on Suboxone. You send them to me the next day, and it's good to go. It's really easy to do.
I would love to be able to do that.
Time's up. Dr. Carey.
Thank you very much, Mr. Chair. And I want to ask an opinion question because, with Dr. Wood, please don't take this as one being pitted against another, but we've looked at the stats for the Insight website itself, and it does seem to be a positive slant. Since it's opened its doors, we've got the stats from 2007. There's been about 3.5 million visits. There's about 18,000 registrants over that time period. And my question really is about how do you define success and how do you find good value? How do you define good value for dollars and resources? Because I think everybody's in agreement. You have to have a comprehensive approach. But on the website, they're saying out of those number of visits, 1,200 people have gone to transitional housing, but it really doesn't say how many people have actually been managed properly through treatment. There's nothing there. So 1,200 out of 18,000, that's like a 6.6%. If they're calling going into housing, that's the success measurement. So I'd like to say, is that how they're measuring success, and is that any indication of how many people are actually being treated properly? And then also, Dr. Eugene Walla, if you could give us an opinion, because there is a cost for Insight. And the police association said even the police officers that get diverted down there, there's 100 of them. If we multiply approximately $100,000 per officer, that's $10 million. That doesn't include the fire, the paramedics, and things like that. If you were given the resources for, those millions of dollars into the treatment, do you think you'd be able to get out of 18,000 registrants? How would you define a success rate with those numbers?
Sorry, are you asking myself or Dr.
I'll
Wood?
ask both of you, so you can start if you want. Yeah.
It's the thing is that the endpoints are different. I think from an infectious disease public health standpoint, that's why these things are getting started. We support a safe injection site in Ottawa. I do. And I'm involved. I started a hepatitis C clinic in Ottawa, so I'm all into public health. I think everybody's getting confused with what you're saying about success, what the endpoint of success is, and how do you define success. So for these people, success might be having their own bed to sleep in and having a meal. So that's the problem, is that you've got to define it properly. And in medicine, we take a lot of time to define what success is and what the gold standard treatment is based on evidence. So if the success of your daughter is the best she can do is get off the street and have a clean bed, and that's what you want, and I tell my patients it's like you're on the C team for hockey, but then there's a B team, an A team, a AAA team, and they all have different, sort of expectations of do you want to be a guy that has a job and a family and pay taxes and enjoy your life, or do you want to be the guy that has to go and assault people and steal and rob pharmacies to use? Like, I don't know, which team do you want to be on, and do you even know what the teams look like? And so it's very hard on paper to write out, this is a success, we save lives. And, my position always is, I don't know, you think you're saving a life, but the people are so unhappy and miserable, and they're living hell. I mean, why do you go, we're saving a life, so therefore we should put this money into it? It should be more what's important, and should you change the whole system so that people have the opportunity to have housing and have, education and have a treatment of their illness. I agree this argument. I listen to a lot of the police. I've been involved with the police chiefs of Ontario, and they're frustrated. Of course they are, because think about it. These injection sites, when you go in, they're not giving you the drugs. Okay, you've got to bring your own drugs in. So you got to go and do all your criminal activity, let's say in Ottawa, downtown the market. So you got to prostitute, steal, or sell drugs. Then you get your drugs, then you walk over there, and then you inject. And then, you're finally asleep and you feel good, and somebody wakes you up asking if you're dead yet. And then you wake up, and then you got to leave. And then you got to go get more, $300 more. So you got to do more crime. So it's not really changing anything. To me, the point is that you're enabling or encouraging a negative existence, and at the same time saying, hey, you didn't die today. So that's a good statistic for this funding. But I just think everybody's missing the point on it. If that's all you have, and you live in a war-torn zone and it's the best you can do, okay, great. But I think we'd all agree in every other aspect, whether it's education or, other areas of portfolios that you all have in military, for example, we want the best. We want the best in our military. We want the best in our education. Everybody wants to send their kid to private school. So why is it different in this area? This is people's lives. They're sick. They have a treatable illness. Why don't you treat it if you can? If you can't treat it and they're palliative and they're going to die, okay, that's fine. They die. But, to Dr. Wood's point, these hepatitis C guys, I got guys on like it's almost $100,000 a month for treatment of hep C. Are you kidding me? And they're homeless. And hey, we didn't really talk about jails yet, but it's like $120,000 a year to put these guys in jail. That's expensive treatment. And trust me, they look better when they come out of jail because simply they haven't been exposed to drugs, they've been eating, and they have a safe place to live. So that could be an end point, but that's an expensive way to treat somebody. So I don't know if that answers your question.
It gives me an idea because I think it is a struggle for all of us.
Dr. Fry.
Sorry, I was hoping I could hear Dr. Wood answer his part of the question, but I just wanted to focus on something here. I am not a member of this committee, but I came here and I saw that you were studying the opioid crisis. So I want to go back to the issue. I think that I am in full agreement with Dr. Wood that we need to look at this from a public health point of view, and then, of course, see what happens when people are in treatment. How do you support them? How do you rehabilitate them? Housing, all of those kinds of support systems that need to be there to back them up once they've been treated. But I just want to quickly say, because I don't want to use up my time, that Jenny Kwan and I were ministers who were in charge of the Vancouver Agreement, out of which came the safe injection sites. And this came out of evidence base that had happened in Europe that dealt with some of the issues. We were dealing with people who were dying massive. What we're dealing with now, if 1,000 people in British Columbia die from an overdose this year, if that had happened because of bacteria or virus or tainted meat, we would be rushing around trying to stop it. I want to talk about all of those elements. One, what do you do immediately to stop those deaths? Because I think you can't measure deaths on a level unless you think that people who die because of substance abuse are not worth it. It's okay for them to die. We're talking about deaths. We're talking about stopping deaths. We're talking about preventing disease. That's a public health piece. I would like Dr. Wood to tell me what is it he thinks that we should be doing immediately right now. I know that and I think I reiterate the question that C2 has stopped people from accessing this immediate treatment of stopping overdose deaths, which is what we intended to do, and we were very successful. People's lives were saved. So what I'm saying is, what are the other things, Dr. Wood, do we need to do on an immediate basis? You talked about the long-term and the medium base, which is the training of doctors, looking at clinical guidelines. What are the immediate things we need to do now to stop real people from dying? What can we do now?
So I'll try to answer that as well as the earlier question in terms of success and where we should be investing, because just to give you a sense, these programs, they're not clinical trials, so we have to look at data on deaths and things like that. And to give people a sense, when the Insight opened, it was in the midst of a public health emergency, as was mentioned, and we had the highest rate of HIV infection in the developed world. Because of the comprehensive approach, which has included Insight, we have seen a greater than 90% reduction in new HIV infections. Insight is a public health program. It's not a housing program. It's not a treatment program. So placing those types of expectations makes no sense. So because people are dying, and British Columbia is on track to have over 1,000 people die this year, young people in the prime of their lives, we need public health interventions, and we need them now. Things that are mentioned like take-home naloxone, absolutely. Public health strategies to address overdose, including supervised consumption. And I think the Band-Aid point is a good one, and that when people are bleeding, you need Band-Aids. But you also need more comprehensive approaches to prevent bleeding in the first place. So we don't want to have a system that just, pulls people out of the river without going upstream to figure out why they're in the river in the first place. So very just structural issues, a national approach to the treatment of opioid addiction, which the Canadian Research Initiative, funded by the federal government through CIHR, is intending to do. The other is training healthcare providers, and to use the example of Winnipeg in the emergency room, in Vancouver Coastal Health, which has been dealing with this for a long time, there still have not been the dedicated resources so that emergency room physicians can just pick up the phone and say, I'm sending someone over to be initiated on Suboxone, or I've started it tonight and they're going to have an appointment tomorrow morning. And again, I'll go back to my point about mental health and substance use. We need strategies focused on substance use, and can't develop shifting money to mental health and substance use, or it just will not trickle down to the needed substance use interventions. So focus on guidelines, focus on practitioners, and don't divide these types of interventions as in opposition.
Thanks, Dr. Wood. Do I have a minute or
10 seconds?
Thanks very much. I just want to quickly ask one question, and you've talked about the immediate things that we need to do, which is what I'm concerned about right now, and I agree with you on the long term and the comprehensive. Big question that I want to ask you: what is the role of heroin assisted treatment in opioid addiction? Is there a role for people to go on heroin or heroin substitutes?
So really what we need, and as we have for other diseases, is a stepped care model. For some people who are opioid addicted, they actually don't need Suboxone. They don't need a medication. Going to a peer support meeting or going to a recovery program, they will go into long-term recovery. They don't need an intensive medical approach. For other people, Suboxone would be effective. If that's unsuccessful, we would look to methadone by the current Vancouver Coastal Guideline. There's other new emerging therapies using long-acting oral morphine as an agonist therapy that can extinguish illicit drug use. For some people, and again, it's almost an inconsequential fraction of the population in terms of population size, but in terms of cost, they can be extremely costly. These are individuals with huge histories of trauma, oftentimes fetal alcohol syndrome and other sort of diseases of the brain that result in compulsive behavior, hypoxic brain injuries. For those people, the science would suggest that very tightly controlled programs where people get diacetylmorphine — heroin's actually the trade name of a drug that was once marketed by Bayer Pharmaceuticals — there is a role. It's not like we're talking about heroin programs rolling out across the country in suburban areas, but for a sliver of the population, it can add a great deal of public health and public safety in terms of being able to successfully engage people in a program. But for many others, and a huge group, no medication might be required. But as my colleague has alluded to, those programs don't exist. So it's really a comprehensive approach and an evidence-based medicine approach. There's a Cochrane collaboration meta-analysis looking at the trials of diacetylmorphine prescription demonstrating the benefits. So I refer to that.
Okay, thanks very much. Ms. Kwan, 3 minutes.
Thank you very much, Mr. Chair, and thank you again to the witnesses. I just want to go back to the crisis that we're faced with today. I know that the Vancouver Medical Health Officer, Patricia Daly, has publicly stated that in their application for additional supervised injection facility has been hampered with delays as a result of Bill C-2. And so the onerous requirements in trying to move forward in coming up facilities to save lives has been severely hampered, and she has articulated that on the public record. So I know that the Health Authority in Vancouver is attempting to get 5 additional supervised injection facilities up and operating in the interim and in the midst of this crisis. So Dr. Evan Wood, do you know anything about that process and whether or not additional sites would be effective in saving lives?
Yeah, for sure. I mean, there's long wait times to use Insight. There's scientific papers showing that among the reasons that people will go and inject in the alley, and just to describe for people, it is a horrible life, as my colleague has alluded to. People using puddle water, where people are defecating in those same alleys and drawing up water into used syringes and injecting street drugs into their arms. People will often do that because they're in severe withdrawal. They're at risk of a negative interaction with a street predator if they're standing in a lineup. They can't get into a health program, and they'll go and they'll inject on the street. So we need to scale up these programs, but as I've said, and you're hearing, the funding for these things is actually relatively small in comparison to the huge money that's going into the downstream consequences of addiction, and that money would be much better spent on effective treatment programs so that we can do the public health side of things and also the recovery-oriented system of care that does not exist and really needs to be developed. In terms of the legislation itself, it's my understanding that the federal government is working with Vancouver Coastal Health within the existing legislation, but that public health officials like Dr. Patty Daly that are involved in that feel that the legislation is onerous and really is not supporting any sort of positive outcome in terms of what it may have originally been intended to do.
Thank you. You mentioned about investment into addictions and the need for a comprehensive approach. I absolutely agree. I think harm reduction is one pillar. I hate to think that if my daughter or son was addicted, that they would die injecting, and that I would want them to survive that experience and to be able to move forward to the next phase, hopefully detox treatment, and then with hopefully a successful life. I keep thinking about that because my constituents lose lives. They're somebody's son, somebody's daughter, and it's very real. So with that in mind, in terms of the other pillars, so we now know what the issues are with harm reduction and the need to move forward. With the other pillars, I get the point about the need for treatment and additional dollars. So if we have $40 billion, I think, Dr. Wood, you mentioned, that would otherwise be spent because of addictions. If we were to invest that money into addiction prevention, treatment, harm reduction services, what would that look like? So can you, in your dream world, what would that look like? What kind of investment do we actually need for a comprehensive approach across this country to deal with this issue in a comprehensive way?
So from a prevention perspective, unfortunately, the science doesn't point a clear path forward in terms of, discussing with youth in high school. Those types of interventions have traditionally been shown to be ineffective. But from a prevention perspective, certainly a national approach to prevent the unsafe prescribing of opioids is clearly needed and something that this committee can push for in terms of a monitoring system to ensure that prescriptions are safe. In terms of treatment, we need accessible treatment. We're just spending so much money in terms of downstream consequences of addiction. So absolutely, we need that, and we need public health approaches too, as was alluded to by Mr. Levesque. Many people, and some I've described, very, very traumatized or people with hypoxic brain injuries or fetal alcohol syndrome, even if the door to treatment was open, they may not be motivated to go there. And we have prisons, and prisons, I agree, people oftentimes, that is a chance to turn their lives around. But in far too many cases, people come out of prisons at great taxpayer expense only to relapse and go immediately back to substance use treatment because there's no treatment in prison. So we need a comprehensive approach, and I think we've focused way too much energy on treating this as a criminal justice issue, and we've spent lots of money there. And I would argue that sort of the war on drugs approach has led to ever more potent drugs like fentanyl, and it needs to be looked at as part of the problem.
Dr.
If I could just add, Ms. Kwan, to that, thinking outside the box, we've been approached by a group in Sweden and also a group in Kentucky, and what they do is they have facilities that they they have built where the people are diverted from jail. Instead of going to jail, they go to these facilities. And in those facilities, they're encouraged to work very quickly, and the state owns these things. And so that they own companies like painting companies and catering companies and whatnot. And then the individuals are given a sense of self-esteem and order and whatnot, but they're encouraged to have high productivity. So the guys from Sweden came and showed me that program, and it looks amazing. The same thing that is happening in Kentucky. They have 2,000 beds in Lexington where they have the same approach happening, and it's working really well. So I think looking outside the box of Canada could be of use to us.
Can I just ask?
Time's up. Way over. Look, I just want to say on behalf of the committee how much we appreciate your testimony. Those of us who have not been exposed to this, I mean, this is a profound testimony, and we really very much appreciate it, and we appreciate what you do. And Dr. Ujinwala, you've offered the committee a visit to your recovery in Ottawa, and I've asked the clerk to check to see if we can do that. I'm not even sure we can do it, and then we'll discuss it as a committee if we have the time to do it. And if the committee chooses to do it, I think it would be helpful to us to see that. But that's just my thought. But I want to thank you both very, very much for what you do and for coming today and for testifying and providing us with this information. It's very moving, very profound. So thanks very much. We have committee business, but we don't have anything on the schedule. We good? All right, I'm going to adjourn the committee. Thank you very much, everybody, and thank you, committee. Great question.
Thank you.